Good everyone. My name is Drew Ward. I am an infectious diseases pharmacist at WVU Medicine in Morgantown, West Virginia. This portion of our didactic presentation today will review a little bit about antimicrobial stewardship and OPAT here at WVU Medicine relating to our practice. Then Dr. Johnson and Dr. Juskowich will share a little bit more about our OPAT and COpAT programs, respectively, after I finish up. So the purpose of this presentation today is really to just define antimicrobial stewardship both broadly and give an example of how our services work here at WVU Medicine in Morgantown, and an outpatient parenteral antimicrobial therapy, or OPAT, as well. So first with AMS, what is stewardship? What's the definition, kind of straight from Webster's dictionary? Stewardship refers to the job of supervising or taking care of something. And piggybacking off of that, antimicrobial stewardship, in a consensus definition by a number of different ID institutions across the United States, defines it as coordinated interventions that improve and measure the appropriate use of antimicrobial agents by promoting and selecting optimal drug regimens, including like their dose, their duration, and the duration of therapy and the route of administration. So put maybe more simply, we're wanting to make sure when practicing antimicrobial stewardship that we're selecting the right antimicrobial for the right organism or bug at the right dose and route for the appropriate duration. And everyone involved in a patient's care, whether it be an inpatient team or an outpatient clinician, is an antimicrobial steward, and all have the opportunity to impact these 3 or 4 aspects of antimicrobial stewardship. Why do we need AMS? Well, studies have indicated that upwards of 50% of antimicrobials prescribed are suboptimal, meaning they don't meet all 4 of those criterion for appropriately stewarded regimens. And misuse of antibiotics can be detrimental to the patients we care for. They may lead to unfavorable outcomes such as C. diff infection or select out resistant organisms, such as extended spectrum beta-lactamase producing organisms or carbapenem resistant organisms. So benefits of stewardship, in addition to decreasing those couple of things I just talked about, also is a means of promoting patient safety, and beyond that, optimizing resource utilization. So certainly in our case and in certain other scenarios, making sure we're using drugs in a cost-effective way that also benefits the patient is another aspect of antimicrobial stewardship. If you joined this presentation last January, this information has been updated with the most recent outpatient antibiotic prescription rates as of 2024. So the data from the CDC lags about a year behind from the year we had just completed in January of every year. And you can see that our state here that we are broadcasting from in West Virginia leads the country in outpatient antimicrobial prescription rates as of 2024, with nearly 1.2 prescriptions for every individual in the state of West Virginia. We were 2 in this ranking, I guess you'd call it, the last couple of years. But recently, in the most recent data, prescribed the most antibiotics per individual in the country. How is this trend? What's the outlook on this trend really over the last several years? I pulled this data from, again, the Center for Disease Control and Prevention website from the past 15 years or so, just to trend and get a visual idea of what outpatient antibiotic prescription rates in West Virginia have looked like over the past several years. Certainly, if I placed a trend line on this graph, it would be down over the last 15 years. You can see there's a discrepancy with the COVID years of lower prescription in an outpatient setting for antibiotics in general. But just based on our ranking relative to other states and the national average, on this last slide, there's certainly work to do here within our community. That was looking a little bit about outpatient antibiotic use, but we also, relative to other states in our region in the United States, typically average more inpatient antimicrobial use relative to other states nearby. So this is comparing, seeing the smaller inset picture on the right, SAAR or SAR value, which is a measurement promoted by the CDC and NHSN that essentially allows us to compare antimicrobial use relative to other states and on a hospital level, other facilities like ours. Ideally, we would want to be at or below the national median value, and you can see as of 2021, I believe this is, we were slightly above that. So in terms of promoting and practicing antimicrobial stewardship, it's certainly an area of focus for us as a health system going forward. Not only that, but having antimicrobial stewardship programs are best practice and more or less required. The White House in 2015 published a National Action Plan for Combating Antibiotic Resistance. Guidelines were published by infectious diseases societies in 2016. And maybe most notably, the Joint Commission, which is an accreditation council for a number of hospitals, requires antimicrobial stewardship to be established for full accreditation. And those guidance were most recently updated in July of 2022. The CDC themselves also publish core elements for antimicrobial stewardship programs for a number of settings, including hospitals, skilled nursing facilities, the outpatient setting, that we strive to meet when impacting our practices here at WVU Medicine. So looking a little bit about at the core elements themselves, just as a background for what we're talking about, they recommend and emphasize the importance for hospital leadership commission, so making sure we have the right financial and human resources able and available to affect change in the antimicrobial stewardship realm. Accountability, so as part of any antimicrobial stewardship program, they recommend that we have a leader or co-leader, either a physician or a pharmacist, typically both, that's responsible for the management of the program and tracking outcomes. Having pharmacy expertise within an antimicrobial stewardship program is essential to understanding appropriate dose, duration, and all those things we talked about earlier. We should be able to implement actions and interventions and be able to track the outcomes of those interventions as a means of establishing a stewardship program. We're also regularly required to report information on antibiotic use and resistance within a health system or a hospital. And a core element of a stewardship program also is education. So that's ensuring that our prescribers, our fellow pharmacists, nurses on the floor caring for patients in clinics, all are aware of and given the best tools to combat antibiotic resistance and be a good antimicrobial steward. You can see these core elements were actually tracked as a means of compliance in the hospital setting over the last 10 years. And in 2014, really only around 40% of hospitals met the CDC core elements for an antimicrobial stewardship program. But as of 2023, compliance for meeting all of those we just discussed exceeded 96%. So nationally, this is something that's been in the forefront over the last decade or so that we're making progress on. This provides an example antimicrobial stewardship workflow for how we go about performing audits and implementing prospective work and stewardship here at our institution. Many different hospitals, facilities, health systems have different ways of going about this. We use what we call a tiered workflow, where we prioritize things that might need to be looked at more readily on a daily basis as tier 1, all the way down to tiers 2 and 3. So these would include typically a prospective audit process of looking at low drug mismatches, anyone with a positive blood culture, restricted drug audits, de-escalation alerts, reviewing any patient on antiretroviral therapy for HIV, just to name a few examples. Shifting from antimicrobial stewardship to our OPAT program, or outpatient parenteral antimicrobial therapy. The goal of the program here at WVU Medicine, and certainly I'm sure for most programs throughout the country and the larger infectious diseases communities, to ensure that all patients that discharge from our hospital on IV antimicrobials complete their treatment safely and effectively. To give a bit of background about how our practice and really workforce has changed over the last 8 years or so. When our program was first established in 2017, then we only had a single dedicated physician and pharmacist to the practice of OPAT. Now, as you'll see, we've grown the OPAT program and established a COpAT program as oral antimicrobial therapy has kind of come into the role of treatment in deep-seated infections. So in the last 8 years, our OPAT program and capabilities have grown substantially. We now have 2 dedicated physicians to the OPAT service, 2 LPNs that help assist with coordination of safe and effective outpatient antimicrobials, and 7 infectious diseases pharmacists now that rotate through OPAT and other ID responsibilities within our local infectious diseases pharmacy services team, all working to ensure that mission of OPAT that I mentioned a few slides ago. These are photos. Would you like to pause on those? I won't. So just a statistic breakdown, we see about 1,000 to 1,500 consults annually on OPAT. Since the program's inception in 2017, have followed over 11,000 courses of antimicrobials to their completion at home. We'll follow patients in West Virginia and neighboring states. So we're a tertiary hospital here that gets referrals from a number of smaller critical access facilities in Ohio, Maryland, Pennsylvania, Virginia. They may all fall under the hospital's OPAT program once they're referred here. And our model has helped to develop OPAT programs elsewhere and across the United States at a number of institutions, including pretty prominent ones such as Cleveland Clinic and Johns Hopkins Hospital. Lastly, I just wanted to illustrate a little bit what the patient journey looks like for OPAT here at WVU Medicine. So once a patient's admitted and determined to have an infectious disease, OPAT's consulted, usually in conjunction with an infectious diseases consult as well. Excuse me. The OPAT team will get a consult. We'll review antimicrobials and create a monitoring plan, place a note, and discuss the appropriateness of an antimicrobial plan with the inpatient consult team. And then after discharge, our nurses, physicians, and pharmacists will follow the patient wherever they may go, whether that be home with home health services to a skilled nursing unit, or acute care, long-term care facility, or a rehab facility. And once out of the hospital, our team's responsible for monitoring their lab work, calling and checking in on patients, managing any adverse effects, adjusting regimens, including sometimes adjusting to oral regimens for the remainder of their course where appropriate, and ensuring they get adequate follow-up. And once the patient's line is removed in the case of OPAT, that's when we sign off and their antimicrobials are completed. I'm going to pause here since I'm seem to be losing my voice, but Dr. Johnson, anything else to add on the OPAT side of things?
Sure. Thanks, Drew. Drew always does the best way, like the best job, like describing everything. I will say from an OPAT standpoint, it's a treatment strategy. When I think about OPAT, what I initially thought my job was when I first started is way different than what it is now. Uh, um, uh, so uh, every decision you have with OPAT is really twofold. So of course you have like what treats the bacteria, what will treat the infection, but then the other aspect of that is what's the most safe regimen for a patient. And what's unique about our OPAT program, which Drew kind of touched on, is we follow them no matter where they go once they leave the hospital. So if that's an acute rehab facility like Encompass, where they have nursing that's equivalent to what we see in the hospital versus, home. And being able to consider that when you're picking a regimen can be really important and also help with the success of the patient. One of the biggest things, when I first started, it was during the pandemic, like follow-ups and keeping in touch with our patients was that much more difficult. So my thinking, the first time in my career was, if they have a duration, as long as they complete it, like maybe that's the best option. If we're going to plan for 6 weeks, they complete 6 weeks. At least we know their infection is treated. With COPAT, with experience, my thinking has really changed. If you're checking labs weekly or biweekly, your next thought should be, if I have a medication I'm giving a patient that I have to monitor weekly, when can I stop that medicine? Like instead of like, okay, here's our finish line. This is, hard number, like we just got to get to here. Like, when do we like have that balance where we treat the infection and we hopefully avoid unnecessary side effects? So I know that now with time and with a lot of wonderful support from ID Pharmacy, from COPAT, from everyone who taught me that seeing patients, it's more about, okay, like when are we more comfortable? Does every endocarditis need 6 weeks? Does every diabetic foot need 6 weeks? When can we like start cutting that back? And then also, of course, during oral transitions, if we feel that IV kind of induction is what's necessary. Those were kind of my big comments. Anything I'm missing, Drew? Or
I've always thought of OPAT and COPAT programs as safety net programs. On the inpatient side, it's very easy for me to make a recommendation, be done. There are so many steps that are needed to make sure that those get implemented. I've heard you guys on the phone so many times, so often, trying to get the medication, making sure the doses are right and things like that. So that's the safety piece of it. And as that grows and develops, and the safety piece, which is the fundamental foundation, gets well established, then I think you start encroaching upon shorter is better. How short is short? Are there safer therapies?
Yeah.
Those kind of things. So I see these as building blocks from that foundation of safety that you established.
yeah.
I don't see any questions yet. So if we want to start with the COPAT presentation and then see if there's any questions regarding that.
The continuation of Drew's presentation with a few more slides focusing on our COPAT program. I'll share the screen. Can you all see the slides? Great. The objectives of this presentation are going to cover the COPAT program and talk a little bit about our service to state mission. So what is COPAT? So it has been defined as complex outpatient oral antimicrobial therapy. And we do ask the question, what's so complex about it? We actually see it as a simple option, but it's using oral antibiotics that achieve high blood levels or have high bioavailability in place of IV antibiotics. So there's a lot of literature to support using oral antibiotics for infections on this end of the spectrum. Traditionally, the hardest to treat infectious diseases, endovascular infections, and bone and joint infections, dating back to landmark trials in 2019. And since then, there have been over 20 published studies and reviews. We're also becoming more and more comfortable using oral antibiotics across this infectious disease spectrum. The WVUH COPAT program is actually developed in 2021, matured in 2022, but is an interdisciplinary team providing monitoring and adherence counseling to select patients on oral antibiotics in the outpatient setting. The main goal is to optimize patient care by preventing hospital admission and readmission, avoiding need for IV access, and facilitating earlier hospital discharge. And targeted infections here list really all infectious diseases except central nervous system infections. So brain infections aren't included on this list because we don't have as much data, although we do sometimes use oral antibiotics. So who's eligible for our COPAT program? It's patients being discharged on at least 2 weeks of oral antibiotics when we have an appropriate agent for the infection type and pathogen. And if the patient's willing to take oral antibiotics, and then also participate in a safety monitoring program. So COPAT COPAT consult order is placed in Epic, and then there's a note placed in the chart. Antibiotics are then dispensed by either our discharge pharmacy or another pharmacy. And then our COPAT team calls the patient for medication reconciliation. So that's usually about 2 days after hospital discharge. And then weekly to discuss adherence, side effects, and lab results. And we document a note in the chart. And our ID pharmacy team is very helpful here. And then the patient seen in COPAT ID clinic approximately 2 weeks after hospital discharge or whenever is felt most appropriate to see that patient in follow-up. And that's often also at the time of maybe determining if an antibiotic course may be shortened. We see them at that point. So to spread our COPAT concept, we took 2 approaches. So one is to hospitals without ID faculty, where we developed the Comparing Oral versus Parenteral Antimicrobial Therapy, or COPAT trial. And that was conducted across 5 ID faculty staffed hospitals in the WV Medicine health system. And they're shown here on the map. The other approach at consults at hospitals without ID faculty is we developed a COPAT ID consult program, which actually started practicing the COPAT principles in the inpatient setting of early oral antibiotic transition, and shorter duration is better when appropriate. And so our program really developed a Princeton Community Hospital in collaboration with an ID pharmacist there. And Dr. Sori and I started the program at Princeton and then developed it into our ID Gold service, which is an e-consult program that now serves Princeton, Potomac, Reynolds, Wetzel, and Fairmont. And we're adding another hospital here probably later this month. So focusing on our COPAT trial. This was a poster that we shared at ID Week 2024 with preliminary results of our COPAT trial. Our COPAT trial has actually now been completed, and our manuscript's been published in Clinical Infectious Diseases, entitled Using the Comparing Oral versus Parenteral Antimicrobial Therapy, or COPAT clinical trial, to influence institutional practice transformation towards early transition to oral antibiotics. The results of the COPAT clinical trial showed that early IV to oral transition significantly improves antibiotic treatment safety without compromising effectiveness across most serious infectious diseases. Patients were surveyed and report a strong preference for oral antibiotics, and the provider comfort with early IV to oral transition increased. And this was measured through Jeopardy teaching sessions that were administered across multiple forums as well as at the time the trial started, our OPAT program was very well established. Our COPAT program was newer. And as we enrolled more patients in the trial, our ratio of COPAT to OPAT consults did increase, with providers becoming more comfortable with sending patients out on oral antibiotics. So through our COPAT trial, as well as our ID Gold service, our eConsult program, we found that, the COPAT program is not only an outpatient program, again, it also starts in the inpatient setting with earlier inpatient transition to oral antibiotics. We found that this leads to earlier discharge, decreased length of stay, and decreased total antibiotic use. So we asked the question, will this also result in, decreased nosocomial bloodstream infections, with patients not having Lyme being discharged sooner, decreased multi-drug resistant organisms, decreased nosocomial issues like DVTs and pressure sores. So in summary, we feel that oral or early IV to oral antibiotic transition is safe and feasible. It has the potential to have significant downstream benefits. And our ID Gold service is the prototype to be used for our service to state mission. We're just a few extra slides on COPAT, and thank you very much. Any questions about the presentation for the COPAT program?
We did have a question through the chat, and it says, this is a great program, and I can see the benefit of the program. Curious about the cadence of the follow-up while on long-term therapy. Who does the follow-up calls and how often? Does the program include directly observed therapy?
Yeah, really good question. Start with the last one first. So does the program include directly observed therapy? The answer there is no. We do find that patients overall are good at taking their antibiotics. They want to take them and get better. But through our monitoring program, we do ask them about, adherence, if they're taking their antibiotics, reminding them to take their antibiotics. And so that is a component. As far as the cadence of follow-up, our ID pharmacists do the follow-up calls. And so that first call is at the hospital discharge or medication reconciliation about 48 to 72 hours after hospital discharge. And then all patients will get a call at about 1 week after hospital discharge. And the ideal model are the patients that need closer monitoring get calls weekly, and patients that are more stable on doing well on therapy, we may decrease those calls as we go on. And then as far as, I guess, another part of that is the follow-up in the ID clinic. The patients, we do those either in person or virtually, so through telephone or through video. And that was really adopted in the setting of COVID when this whole program developed, but have continued to use, that we find is useful in kind of a rural state or in Appalachia to get patients in follow-up. Any other questions?